Thanks so much, Angelina. That was powerful. It's my pleasure to be able to bring up Ms. Amy York, who is with Eldercare Workforce Alliance, to share her experience and expertise on this matter.
Hi. I know you're probably starting to fade. The lunch is kicking in, and so I'm gonna try and move it along. But I do want to share some kind of unique things from the entire workforce perspective. And I appreciate the opportunity to be here, really, to be part of this conversation. Okay. So we actually had the opportunity to put this in the book, but I wanted to share it now because I think it's important as I'm discussing this that you understand where I'm coming from. This is our membership list. We have 35 organizations that are part of our national coalition, and those organizations represent consumers, family caregivers, direct care workers, providers, and healthcare professionals. So we really are coming at it from a whole team perspective, and we're looking at the team as big, and that we need to include everyone in this discussion and everyone at our table. We look at developing policy solutions to advance this workforce. And we are supported by the John A. Hartford Foundation and Retirement Research Foundation, as well as membership dues to do this work. So another thing that I felt was really important to say is that we were actually formed out of a National Academy report, and it's not just sitting on a shelf. We're actively working on trying to implement recommendations. It was the Retooling for an Aging America report in 2008, and it really challenged us to think about how care is delivered, but also the preparation of the workforce that's providing that care. Specifically, the report looked at team-based care and how we can improve the workforce through team-based care and having everyone work at the top of their skill sets. Another report actually was also produced at the National Academy, or it was actually the Institute of Medicine at the time, on mental health and substance use workers, and noting that nearly 1 in 5 older adults in America has one or more mental health or substance use conditions. So those have kind of been the backdrop of our work. We're actually currently in the process of developing and updating the data that was included in the 2008 report. It's not complete yet, but I'm going to share a few details about some of the data that we have developed. So Joanne talked a little bit about the overall numbers, but this is comparing what was available in the 2008 report and what's happening now. And the numbers and increases in this workforce, which this is the overall workforce, aren't dramatic considering it's a 10 to 13 year span. But it also does not reflect specialization in geriatrics. So those numbers would be far less, and it's safe to say that we will not be meeting demand in terms of those numbers. I would also like to focus a little bit on the direct care workforce and the shortages in that workforce. Unfortunately, this workforce, the workforce that is providing long-term services and supports to older adults, is largely invisible, and people have been unaware of the need for this workforce until a personal crisis occurs with themselves or a family member. Those working with older adults have known about this problem for a long time. However, I'm seeing a tide changing. There's definitely some realization, especially at the state level, that we need to focus on this workforce. I think that that's due in part to the critical shortage of healthcare providers with specialized training in geriatrics across the board, from geriatrics to the direct care workforce. This, in its initial meeting, the Raise Family Caregiver Advisory Council recently determined that workforce was one of two priorities for two of the three work groups. So family caregivers recognize this issue and problem as well. The panel was formed to develop a national strategy for family caregivers. So I think they're an important voice for us moving forward as we talk about the solutions as moving forward. When families need help, they do turn to paid help, primarily the direct care workforce, who provide hands-on care that allows individuals to remain at home as long and independently as possible. The majority of home care workers are personal care aides. In 2015, the demand was approximately 2.3 million direct care workers, and based on the projected demand by 2030, an estimated 3.4 million direct care workers will be needed in long-term care settings. A former state Medicaid director recently stated, without a big enough and stable direct care workforce, the whole system of programs will collapse. This ongoing gap exists in all major specializations, providing long-term services and supports, from primary care geriatricians to nurses to the direct care workforce. As Angelina discussed, wages are a big part and a reason for this. So I'm going to just show you some of the changes since 2008 that have happened in wages. They're not dramatic. They're very small. As you can see, it's very insufficient in terms of making a difference in their daily lives. So we really need to work to increase and professionalize this workforce. The Institute of Medicine report also recommended increasing opportunities for comprehensive training of this workforce. In 2008, PCAs and community health workers were the only members of the care team that did not require competency-based license or certification. Today, there are still no federally mandated competencies, professional or education standards for PCAs at the federal level, but there are a few at the state level. For CNAs, there is a federally mandated requirement of a minimum of 75 hours, and states need to comply with this requirement. Some states, as I mentioned, do have requirements for PCAs, but we really need to make this a federal standard and have competencies and skill set to meet the needs of older adults. Another recommendation in the 2008 report was for increased coordination of care. In order to increase the quality of care provided to older adults, we really need an interdisciplinary care team. And an important member of this team is the direct care workforce, and they should be part of this team. But another important member that oftentimes is not included in discussions where they should be is social workers. According to a 2017 report on the social workforce, the number of social workers has increased, and a substantial number without specialty or geriatric training report that older adults make up a large portion of their caseloads. However, it is difficult to estimate how many are specialized in training in geriatrics. Most of the data relates to MSWs. Of those with MSWs going into healthcare specifically, 26.2% are work in gerontology with older adults. That's a pretty small percentage given the amount of older adults that are seeking care and needing services. Out of all of the MSWs entering social work, only 4% are work with older adults and in gerontology. This is not to say that they have specialized training in geriatrics, though. So many of those going into gerontology and geriatrics do not have training in geriatrics. So care coordination really is just an approach to facilitate better communication between and among individuals, family members, and service providers. The current system in the U.S. has become better at communicating amongst these providers, but is still struggling to include others. For example, in the recently released National Academy of Sciences, Engineering, and Medicine report, integrating social care into the delivery of healthcare, moving upstream to improve the nation's health. It's a mouthful. The first recommendation actually is design healthcare delivery to integrate social care into healthcare. And the second is to build a workforce to integrate social care and healthcare delivery. This is especially important in the care of older adults with complex care needs and social support needs. The Older Americans Act actually provides a lot of services that support the social needs of older adults. However, it is woefully underfunded, and there must be increases in those programs to meet the needs of older adults. In addition, the direct care workforce and family caregivers are many times excluded from care conversations, and they provide the most hands-on care. I should say that these recommendations in the National Academy report, many of those same recommendations were made in Retooling for an Aging America. So there's some duplication on what we're saying, which I think means we need to do it moving forward. Okay, so solutions. There are a few programs that have come up since 2008 that I'd like, and this is one in particular that I'd like to highlight. The EWA has led the efforts to advocate and support and expand the geriatric workforce programs that are, they're the only programs that focus at the federal level on the healthcare workforce to maximize patient and family engagement while improving outcomes of older adults. The Geriatric Workforce Enhancement Program, which are the black dots on the map, were awarded grants in June to 48 locations in 35 states and 2 territories. The program, which is administered by the Health Resources and Services Administration, or HRSA, integrates geriatrics and primary care to transform clinical training environments to provide a more coordinated and comprehensive care. It also develops providers who can assess and address the needs of older adults and their families and caregivers. It creates and delivers community-based programs and works with community-based providers that provide patients, families, and caregivers with knowledge and skills to improve health outcomes and the quality of care for older adults. And finally, it educates family caregivers and direct care workers and healthcare professionals, students, faculty, and providers on strategies for caring for those with Alzheimer's and related dementia. In addition to the GWEP program, HRSA also recently reinstated the Geriatric Academic Career Awards. This program provides incentives for many on the care team. There were 26 awards awarded actually in September, and those are the red dots on the map. And both lists are actually available on our website. So a recent national survey showed GACA recipients suggests that programs providing training and educational opportunities have far-reaching and positive impacts. They facilitate professional engagement. 92% of respondents agreed that GACA awards facilitated their professional development, and the awards resulted in dissemination of specialized training in the care of older adults, with studies finding that awardees were able to reach approximately 40,700 learners who might not otherwise have received specialized training in the care of older adults. And that's with very few GACA recipients. So how can we move forward? I mentioned several reports that were done by the National Academy or the Institute of Medicine, and there are a lot of recommendations in there that overlap with each other, that overlap with other recommendations, and I think that moving forward we can look at those keep looking at those recommendations to see where we're falling short and where we need to move forward. Along with the data update that we're doing, we will be looking at the recommendations as well to highlight what are the recommendations that we still need to move forward on. I also did want to highlight integration of the care teams is critical as we move forward and include the direct care workforce as well as social care. Expanding training in geriatrics through GWEPs and GACAs, but also through other means so that we can better understand the care of older adults. And then professionalizing the direct care workforce, which has been a theme up here already. So that's all I have. Thank you very much.